Hello, and welcome to our newest edition of The Heart of the Jersey Shore. Today we have a very special guest with us, Dr. Edmund Karam, cardiologist. Welcome, Dr. Karam.
Thank you for having me.
Oh, we've been trying to do this for a long time.
We have, yes.
Finally, we're here. Tell me about yourself. Why did you become a cardiologist? Why did you become a doctor? What interested you?
I think if you ask most physicians, they'd say it was something that was a calling for them, even at a young age. And I know as a child, I was always interested in the human body and how things work, and the science just behind medicine. Mm-hmm. Science was always my strong suit in school, and when I went to college at MIT, the engineering aspects kind of guided me towards this particular niche in cardiology, which is cardiac electrophysiology.
Interesting.
The heart is an amazing organ for a lot of reasons, besides just keeping us alive. It is a fluid dynamic organ. It is an electrical organ. It's got so many different, physical components, different aspects of physics that make it work properly. So it's anyone who's interested in engineering and science would naturally be drawn towards cardiology. But that on a greater scheme, I mean, it's a very amazing profession in that you get to meet different kinds of people in all kinds of different situations, and you get a real glimpse into humanity. And you get to see sort of what makes people tick, not just it with their health, but with how they live their lives, and you get to be a part of their life in that way, and that's an honor. So it's very rewarding in that sense.
I can see that. So where did you earn your degree, and how many years have you been in practice?
Well, as I said, I went to college at the Massachusetts Institute of Technology, and from there went to Georgetown University School of Medicine in Washington, D.C.
Good school.
Thank you. Great town, too, by the way.
Oh, yeah, fun.
Yeah. From there, I stayed actually at Georgetown for 3 years to do internal medicine residency, which every cardiologist has to do. That's a basic residency. It's 3 years for internal medicine before you can specialize. So then I went on to cardiology fellowship at University of Pittsburgh Medical Center, another great town, by the way. Did my fellowship there, and then finished with an additional fellowship at New York University Langone Medical Center for cardiac electrophysiology.
So how many years was that altogether before you could get out there and really start a practice?
Well, after college, you had 4 years of medical school, 3 years, another 6, 10, 11 years.
Wow. That's a big commitment. You have to be really sure of what you're doing and what you want out of life.
Yeah.
Wow, that's great. So what are your specialties?
Specialties. Well, I'm a cardiologist. First and foremost, and then beyond that, a cardiac electrophysiologist. So my real area of expertise, I would say, is in the electrical system of the heart. For the heart to beat properly, an electrical impulse has to course through the heart, stimulating and making the heart beat in a coordinated fashion. And if something goes wrong, then the heart can become disordered, and that could be either symptomatic or even dangerous. So the cardiac electrophysiology is the study of disorders of the electrical system of the heart.
I don't think your everyday person thinks of a heart that way, but it really is. It's like the engine of a car.
It is very much, and we use that analogy all the time. So there's a transmission specialist, there's somebody who could fix the electrical systems of the car, someone who could fix the tires and things like that. It's hard to envision that, wow, there's specialties within cardiology, but there really are. With that said, I do treat general cardiology ailments and things like of that nature, but really my main focus is the electrical system of the heart.
Well, that's great. So I did a little research, and I wanted to look up patient reviews on you.
Oh,
And I was amazed you have an almost perfect 5-star rating, which is like walk on water with people, because everyone has an opinion and people look at things differently. And that's really a tribute to you. That's really a great accomplishment.
thank you.
So, now we know what your specialties are. What are your areas of expertise? And tell us a little bit about all these different things, like, for instance, like pacemakers, atrial fibrillation, intermittent heart racing, and I don't even know this one, sick sinus syndrome, which sounds like it's up here.
Yeah. Well, essentially, anything can go wrong with the electrical system of the heart from top to bottom. And like I said, sometimes these are just annoyances that are not going to threaten the length of your life, or you're not going to drop dead from them, but they can become disruptive to the quality of life. And then there are some arrhythmias that are true threats to one's life. So, starting top to bottom, the heart has a natural pacemaker called the sinus node that initiates every normal heartbeat of the heart, and that can be it could be sick sinus syndrome.
Okay.
That means one's natural pacemaker is failing to keep up with the person's demands.
Okay.
And that could be in a way that it pauses and stops long enough for someone to pass out. Or it could just be where somebody is trying to exert themselves and they just feel fatigued very early, too tired or short of breath to be able to do what their brain wants to do. So for that, the treatment is either, we always try to see, is there an offending agent? Sometimes that's due to a side effect of a medication, and we can remove that offending agent and relieve the problem. Mm-hmm. But sometimes it is an organic problem of the heart that won't go away without more aggressive intervention. And in that situation, we will often recommend a pacemaker to be implanted that will take over stimulating the heart to beat so the person can live an active lifestyle, not limited by a slow heart rate. So moving down the heart, the top chambers of the heart are called the atria. There's a right atrium and a left atrium. And these chambers will, when activated electrically, squeeze the blood into the bottom chambers of the heart.
Right.
Okay? So electricity is supposed to flow smoothly down the atria into the ventricles, pausing for a split second to allow the blood to fall to the bottom chambers before the bottom chambers are stimulated to beat.
Okay.
If electricity gets caught up in a short circuit in the top chambers, that can cause a fluttering arrhythmia. Okay, it feels like the heart is fluttering. It can become disordered and chaotic, which we call atrial fibrillation. Sometimes there is a tiny little short circuit somewhere that causes the heart to beat rapidly. Sometimes there's a spot in the top chambers of the heart that is like almost like an itch that fires away, taking over, overdriving the sinus node and making the heartbeat abnormally fast. So these are among several of the things that can go wrong with the electrical system of the top chambers of the heart. And we treat these a number of ways. Well, there's medication sometimes that can help reorganize or smooth out the electrical function of the top chambers of the heart. But sometimes medications do not work, or medications become too burdensome to the patient, and we have to do something more aggressive. And this is when we are talking about something called ablation. This is where we go into the heart through the groins with catheters and find where the electrical problem is and zap it out.
And you could actually see that?
Yes, we use very sophisticated software to map the electrical functions of each of the atria, find out where the short circuit is occurring, where the itch is occurring, where the problem is, and target it and ablate it using one of various forms of ablation technology. We can freeze it, we can burn it, and now there's newer technology called pulsed field ablation, which is uses oscillating voltage changes to gently inactivate the tissue, minimizing risk for collateral damage. And that doesn't mean it's superior in every sense, every type of arrhythmia, but the fact is the technology is really becoming so vast that we can tailor the kind of ablation that we, to the specific arrhythmia, maximizing efficacy and minimizing risk to the patient.
And you decide that once you're inside the patient and looking and seeing what's going on and mapping?
Sometimes we already know what type of arrhythmia it is, and we've already got the equipment ready to go. But yes, we're ready to switch on a dime if the situation dictates.
And what does the medication do? Is it slowing the heart down to keep it from racing, or how does it regulate the heart that way?
Some of the simplest medications just block the adrenaline's effect on the heart, because sometimes simply by doing that will slow the heart rate down or suppress some abnormal rhythms, abnormal spots that are firing away. They just need to blunt the effect of adrenaline on the heart in order to accomplish what you're looking for. But really, the medications are vast. There's many different types of antiarrhythmic medications. Essentially, the way cardiac tissue conducts electricity is with the opening and closing of ion channels, which means that ions like sodium and potassium and calcium are used to transmit electricity through the heart, and they have special channels that allow the passage of these ions. Different medications may alter the way those ions process or allow passage of the ions. So it will slow electricity in that way, or otherwise affect the way the heart processes these ions to conduct electricity.
Okay, so then you go further when the medication isn't working and you'll do ablations and what have you.
Yes, and there are some arrhythmias that we know are not very responsive to medications, and we may go straight to an ablation in that situation. Or there are patients who are maybe relatively young and say, I don't want to be on a medication for the rest of my life. Mm-hmm. Or people try medication and there's side effects, and they cannot tolerate the side effects. So there's a lot of reasons why we go to the ablation, but as ablation is becoming safer and safer, we're finding it creeping up the ladder in terms of how soon it is offered.
So, for instance, how many ablations do you think you do a week?
Depends on the week. When I'm not in the office, I seem to be doing them every day that I'm in the hospital. There are some days I'm in the office all day, of course, seeing the patients.
Right.
But just about every procedure day in the hospital, we're doing ablations. It's definitely the most common procedure that I do.
It sounds like it.
Yeah.
Okay.
But moving down the heart, because we're going to go top to bottom. In the middle of the heart is something called the AV node, which connects the top chambers to the bottom chambers, which we call the ventricles.
Right.
And this, like I said, allows a split-second pause between the top chambers squeezing the blood and the bottom chambers squeezing the blood. We can't have the top and the bottom squeezing at the same time. The blood would have nowhere to go.
Right.
So the top chambers squeeze the blood down to the bottom. The bottom is then able to pump out to the lungs and to the body. Now the AV node and the fibers around it can become diseased. That means the top chambers are sending a signal electrically to the bottom chambers. The bottom chambers are not hearing it, which means the bottom chambers, which do most of the pumping work of the heart, are not beating, and the person can pass out. This is when we start worrying about the more deadly type of arrhythmias.
Okay.
This is usually more of an emergency type procedure that we do when we have to emergently put in a pacemaker for someone whose AV node is not functioning.
So that would cause the person just out of the blue to pass out, fall down, whatever.
Correct.
Get hurt.
Now, hopefully, this is something that becomes more insidious over time. It doesn't have an abrupt catastrophic event, where someone says, well, Dad's been dizzy for the past week, now he's a little short of breath, and they come in and we say, oh my gosh, this is getting bad, we should do a pacemaker. But sometimes it's when they have a catastrophic fall, a car accident, and they're brought to the hospital, and we have to just get a pacemaker in the nick of time. But this is when we're moving away from the annoying arrhythmias to the more life-threatening arrhythmias.
Right.
Okay. So pacemakers have been around a while, but they also remain a cornerstone of the procedures that we do regularly.
Oh.
Finishing off as we go to the bottom chambers. Bottom chambers also have a coordinated electrical function that causes them to squeeze the blood as we want them to. Electricity can be caught up in the bottom chambers as well. That is where an arrhythmia we call ventricular tachycardia. This happens often when there's scar tissue in the bottom chambers of the heart, either due to a viral infection or due to a prior heart attack. Mm-hmm. This is also life-threatening. The short circuit of electricity in the bottom chambers of the heart can degenerate into something called ventricular fibrillation, which is essentially the heart stopping.
Wow.
When someone drops dead on the street, it's usually due to a ventricular arrhythmia, such as ventricular fibrillation. For this arrhythmia, the treatment is a defibrillator if the person's lucky enough to survive. Mm-hmm. Also, if we see a condition that puts the patient at risk of ventricular fibrillation, even if they have not had ventricular fibrillation, we offer them a defibrillator to protect them. This is basically like the paramedics following you around all the time with the paddles. And it will shock the heart back to a normal rhythm. God forbid the heart stops. But also, we don't want people getting shocked by a defibrillator incessantly. That hurts. We do ablation in the ventricles as well to burn tissue that causes the short circuit. But we never trust it. We never say that was good enough work, they don't need a defibrillator. We always hedge our bets by putting in a defibrillator to help protect them.
Now, once a person has a defibrillator in, mm-hmm. could they not drive or things? Because I would imagine if it goes off, it's like,
mm-hmm. That's an excellent question, and it comes up all the time. So state by state, there are different regulations. And our job as physicians is to advise people what our recommendation is, but also what the state follows in terms of guidelines. Typically, if somebody has an arrhythmia that causes them to lose consciousness, the concern is that could happen while they're driving.
Right.
And they could hurt themselves and other people. So if they have a defibrillator, it does shock them. It does not prevent them from losing their posture when they're driving. It's not saying, well, I have a defibrillator, now I don't have to worry about my ventricular tachycardia or my ventricular fibrillation making me pass out. People typically still pass out or at least briefly lose their posture. So we say we want to make sure that this arrhythmia is a rare occurrence for this person and is not something that is about to occur more commonly or more frequently. So if someone has an event, we would like them to wait about 3 to 6 months to make sure it's not getting worse before we allow them to drive. That's a New Jersey guideline, but most states follow similar pattern. There are some states that require the physician to fill out a form and report their patient, but many physicians feel that violates the doctor-patient trust, and that
in a way,
a patient should be told given instructions not to drive, mm-hmm. and from there, we expect them to follow those instructions for their betterment of their own health and that the well-being of others.
Right.
But it's on an unpleasant conversation to have with people, saying, we really are not allowed to drive for minimum 3 months when they have a job and whatnot, and they have to help them with disability papers and whatnot. But again, their well-being and the well-being of society at large is a priority there. Yeah.
hopefully they'll be nervous enough not to, you know, drive and to listen. And
Yeah.
scary thing to think about, that there are people out there that, you know, could just like pass out in their car or just like get shocked and lose their wits about them at the wrong split second.
Right. Well, it's a similar philosophy about people with a seizure disorder.
Mm-hmm.
If I had a seizure, God forbid, right now, the question would be, is this the beginning of something? Am I going to start having seizures every week, every month, every year? So we have to wait and see.
Right. Okay. Well, I think we took care of what do you do to correct these areas already, which is great. So now, like, what's the difference between a heart attack and an arrhythmia in both men and women?
That is an excellent question, because there is a lot of confusion about these terms, particularly heart attack.
Right.
If someone is walking down the street and they drop dead, people will say he had a heart attack. But the classic definition of a heart attack is a blockage in the artery that causes a piece of the heart muscle to die. Now, that may cause an electrical disturbance, which is an arrhythmia, but a heart attack is really a plumbing problem. It's where the artery is not allowing passage of blood to a piece of the heart tissue, and the tissue is starving for that blood and starts to die. So a heart attack, let's talk about what we mean with a heart attack. If somebody has a blockage in their artery, the typical symptoms are pain in the chest, or pressure, a feeling of pressure, or someone standing on the chest. And that can radiate to the jaw and to the arm, to the back. It can make one short of breath. Okay? But we have to be mindful that the nerves around the heart are not like the nerves in our skin. If you poked me with a spike in my leg, I could tell you exactly which part of my leg is being poked. But the nerves around the heart are more vague sensory type nerves. So if their heart is feeling pain, a lot of people can't really point to it. It just feels like a squeeze, or and maybe they feel it in their jaw. It's a confusing type of pain, typically. Right. And then if someone is diabetic, those nerves have some degree of neuropathy, so the signals being sent to the brain can be different. Some diabetics won't feel a heart attack, which is scary.
Sure is.
And then, of course, as we parse out all the different symptoms of a heart attack, we have found that men and women often report different types of symptoms. And what we consider typical or classic symptoms of a heart attack are not always reported by women. So women can say, well, the pain feels sharp, the pain feels differently, I'm short of breath. It could be an atypical cluster of symptoms, which is why we should take every patient seriously when they report symptoms that could even remotely be considered a heart attack. But in particular, we have to remind ourselves that women often have atypical symptoms.
And that's where the danger comes in for women.
Yes.
And you were talking about pain in your arm. Is there a particular arm you're going to feel pain in, or it could be in either arm? Well,
we could say it could be either arm, but really classically it's the left arm.
It is the left arm,
yeah.
Okay.
If somebody were to have an arrhythmia, the symptoms can also feel like chest pain, but it can also feel like palpitations. The heart is racing.
Right.
Or they could feel dizzy, or they could pass out. These are typical symptoms of an electrical disturbance of the heart. And keep in mind, if you have a blockage in your heart, a heart attack, that can lead to an arrhythmia.
Okay.
Yes.
So what should one do if they suspect that they are having a heart attack, that they're having some of the classic symptoms, and maybe somebody called 911, is there something to do before that? You know, like the classic thing was, oh, chew an aspirin. Does that really do anything?
So we do know that aspirin is very helpful in the setting of a heart attack, but what we know more than anything is the sooner you can get medical care, the better off you will be. So calling 911 should be the first thing that anyone does in that situation. Now this is different. If somebody collapses, then there's another protocol. Obviously, if it's too far to get to a phone, you begin CPR before you go to the phone. You want to stay with the person and try to resuscitate them. But we're talking in your situation where someone says, I don't feel right, I have pain in my chest, it's going to my jaw, I'm short of breath, I think I'm having a heart attack. That person has to get to the hospital, because the sooner you can open up that artery, the less damage to the heart there will be.
Right. And the most important thing I would say is don't get in a car and drive yourself.
Correct.
Because people do that. They think, oh, nothing's going to happen, I'll get to the hospital in time. And that could be catastrophic.
That is, I'm glad you brought that up, yes. EMS squad are prepared to treat you with a defibrillator or other treatments, whereas you're driving yourself, you're not going to be in a position to do it. Even if you're with your family, I mean, you're really, it's really best to call 911.
Okay, good. I'm glad we mentioned that.
Yeah.
So I know you have a list of hospitals that you're associated with. Could you tell me which ones they are?
Yes. So here at Shore Heart Group, we cover all of Monmouth and Ocean County for the most part, with very few exceptions. So going north to south, we have Bay Shore.
Great hospital.
Mm-hmm. We have Riverview Medical Center that we cover. We cover Centrostate right here in Freehold. Mm-hmm. We cover Jersey Shore University Medical Center, where we are very involved there with not just patient care, but teaching the fellows and students that rotate through. Same with Ocean University Medical Center in Brick.
Right.
We're very involved there, again, with teaching as well. Southern Ocean Medical Center in Manahawkin, and also Community Medical Center in Toms River. We also cover a wide range of rehab centers.
Oh,
Yeah.
Okay. And you have many offices. Your doors usually have no glass, and it's all names.
Yes.
But where are your offices located closest to Toms River in the Manchester area? And then in general, where are your other offices located?
Right, so we have an office in Toms River. We have one right on Mule Road. You can see it from Route 37.
Okay.
Shore Heart Group. We have an office in Brick on Beaverson Boulevard. We have an office in Freehold on Iron Bridge Road. We have an office in Neptune on Route 33, right across from the hospital.
Right.
We have an office in Keyport, which is close to Bayshore.
Oh, okay.
Right, and we have an office in Tinton Falls. And then finally, we have one down in Manahawkin.
Oh, okay. So you really cover the whole shore.
We do. Yeah, we have, and we're expanding because it doesn't look like heart disease is going anywhere anytime soon, and the population that we treat is growing, and we're becoming busier and busier. So we're hiring more doctors.
So are you finding that? What are you finding more of that you're seeing today with our generation coming into older age?
Atrial fibrillation is certainly very common. One of the arrhythmias of the top chambers of the heart that we spoke about, and we see a lot of people coming in for a number of reasons. Number one, because they're symptomatic and they want it treated with an ablation. But also with atrial fibrillation, there is a protective benefit of blood thinners with respect to the fact that when the top chambers of the heart are fibrillating, clots can form there that break off and cause a stroke. So thinning the blood prevents that. But of course, blood thinners also thin the blood. Mm-hmm. And that means people can bleed easier. They can have blood in their bowel movement, they can have blood in their urine, they could bleed in their brain. They can, if they get in a car accident, the traumatic bleeding is worse. For a number of reasons, people are intolerant of blood thinners. They will come and see us, and we offer a procedure called left atrial appendage occlusion, which is a plug that we put inside the heart to allow people to safely come off blood thinners while also being protected against stroke in the setting of atrial fibrillation. That is one of the more common and becoming more common procedures that we do. What else are we seeing? Well, I believe we are getting somewhere with respect to coronary artery disease, because we are now treating cholesterol more aggressively. There are a lot of new options for people who are intolerant to cholesterol medications. We're learning more about what goes into the making of the plaque that blocks our arteries, and we're getting very, very good at stopping heart attacks in their tracks by getting people to the cath lab earlier and putting stents in. So I would say we're seeing less of the long-term complications of heart attacks because we're treating heart attacks faster and more effectively.
That's good to hear.
Yeah.
And that's our generation now.
Right, right.
Well, I want to thank you so much for doing this for us and for our show today. And not to mention that, again, when someone can look you up, they could see almost a perfect 5-star rating across the board, which again is phenomenal. And I firsthand know that you're wonderful because you're my doctor as well. I hope everybody's listening. If you have any questions, please contact us. This is Michael Blank, KLVW-TV. Thanks for showing up. Until next time.